we're starting over, I suppose. Okay. All right. So once again, I want to welcome everybody to the Indian HIV Epidemic Advisory Council for November 2020. Hopefully you are all staying safe and well in this time, and we'll get over to Julie for our call.
All right, the first member I see on the screen is Brady.
Hey everyone, Brady Dell, Edwin Morris. I am the chairman of the National Regional HIV Planning Council.
Brian.
Brian Hale, CEO of Neighborhood Health.
Claire.
Hi everyone, Claire Bolds, Program Manager of the Southeast AETC.
Dr. Kelly.
Sean Kelly, Medical Director of the Vanderbilt Comprehensive Care Clinic.
Rajiv.
Rajiv Mawat, Director of Ryan White Part A here at Metro Nashville.
Dr. Hildreth.
Yes, President of Harvard Medical College. Thank you. Sorry, I can't get my video to work, but I'm here.
We appreciate your presence. And then everybody else, our non-members, do we want our guests to introduce themselves as well? Or just do that as a kind of a on the agenda? Okay. All right, well, it looks like I'm up next in that case. And I did just want to share, given that we're officially a year of meeting with this group, to do, just a brief summary of the past year of this work of this council, and then where we're some of the ideas about where we're going into the next year. So the advisory council, these are some pretty basic metrics, met 5 times. Only did not meet 6 times because our March scheduled meeting was canceled due to the coronavirus, but we adapted fairly quickly and began meeting virtually. This group approved bylaws, elected co-chairs, prioritized a massive plan into 5 very meaningful goals. Welcomed Dr. Michael Caldwell, adapted to the coronavirus, the best that we can, created or adopted a nominations and recruitment plan, and nominated some new potential members. The equity work group was formed pretty quickly, and just want to acknowledge the work of a lot of, volunteers who, come together and meet monthly to help move this work forward. And this group, Dr. Leah Alexander and Tariq Smith are the co-chairs of the equity work group, formed in February, and also was impacted by the coronavirus, and so began meeting, working by email, and then met virtually 7 times this year. They've prioritized the equity-focused work. They formed the Trauma-Informed Care and Cultural Humility Project team, defined radical inclusion, which was included as a guiding principle in the EHE plan, and that really helped operationalize what the nominations and recruitment plan needed to look like. And so that group was responsible for that as well. And the current work of that group is really diving meaningfully into equity metrics, and Dr. Alexander is really guiding a lot of that process, and then currently are working on a project to increase the capacity of community health workers throughout the HIV prevention and care continuum. So again, a group of volunteers coming together to support this work. Want to show much appreciation to the EHE leadership team. And this group was formed in August and have met virtually 4 times. They created the communications logic model, strategic plan for the next year of EHE. So as we're, looking to increase the communications of what we're trying to achieve with ending the HIV epidemic in Nashville. The current priority of that group is the rollout of the additional EHE work groups, beginning with the prevention work group, which is slated for January 2021. And that group did make the recommendation that this council look at Fast Track Cities initiative, which is on the agenda later today, and Claire will speak more to that. And then the Trauma-Informed Care and Cultural Humility Project team has been doing a lot of groundwork looking at what we have in place in Nashville and how we can improve the HIV prevention and continuum of care in order to, promote increased retention in care. And that group has been meeting bi-weekly since July. And they're currently working on developing key informant interviews to determine facilitators and barriers to implementing trauma-informed care and cultural humility in these organizations in Nashville. And just some other metrics. So there's the Ehe Newsletter that's distributed monthly. Really try to promote not just, the work of EHE, but also our partner organizations that are obviously doing so much and have been historically, working towards this goal before there was a plan in place. Internally to the health department where I work, we have an internal stakeholders group that is meets monthly in order to help, align internally our work around HIV prevention and care, as well as syndemic issues. We have been invited to participate with the Center for Nonprofit Management with their collective impact community conversations workshops. And we've had a few of our members participating in those. And I'm very delighted to announce tonight that we have doubled our staff from me to me and Miss Sierra Harris, who is on the line. And Sierra, would you care to give a brief introduction of yourself?
Sure. So, hi everyone. My name is Sierra Harris. I am new to this ETE position. I originally was the Community Health Assessment and Community Health Improvement Plan Coordinator. As that work has moved, I am now back in HIV. I started out at the Tennessee Department of Health under Dr. Chanel McGoy and Carolyn Wester. From there, I went to Vanderbilt, where I worked at the Southeast AIDS Education and Training Center with Jennifer Burge and Dr. Rafonsi. So nice to meet everyone virtually.
And Sierra will be helping to support more of some of the administrative pieces of the advisory council and some of the EHE work, but will also be leading the rollout of the prevention work group and leading from within the department a lot of our prevention-focused efforts supporting increased PrEP uptake, not just within our own clinic, but within our community partners' clinics as well. Doing more youth-focused work, which has been a noticeable gap in what we've rolled out so far. So very, very excited and grateful to have Sierra working with us. Looking forward, I mean, obviously, COVID slowed us down a little bit, but, not, drastically. And, I'm excited about what we have achieved. I think the last year really has been laying the groundwork, and, the next year will really be ramping up the work and getting more projects out and completed. Additionally, the rollout of the work groups, guided by the EHE leadership team, increasing the communication of EHE. I know a priority of this group has been to increase our footprint, our web presence. We do actually have an opportunity, if council members know interested NPH candidates in Nashville's either Vanderbilt, TSU, or Meharry NPH programs, have an opportunity posted through the Region 4 Public Health Learning Center out of Emory for a practice scholar. That's open now, so hoping to get somebody in place to help with some of this communication of our work. And then really a goal, and this was put very well by one of our colleagues, Brad Palmertree, who is on the Trauma-Informed Care and Cultural Humility project team with us. When it's everybody's job, it's nobody's job. And, we rely on the great ideas and the time and the goodwill of people coming to, participate in these work groups. But the more we can get funded positions, people who have it in their job description, that they're, responsible for a piece of this EHE work, the better it's going to go forward. So, and then had the opportunity to reach out to Anthony Benici, who's our epidemiologist in the Ryan White program, and he was able to give us the most recent 90-90-90 data. I put this in the slide backward, apologize, put it in at the last minute, but I did want to show you the comparison from where we were at in 2020 and just in 2016 when the plan was created, and show you the comparison for where we are today. So one kind of noticeable change, and Anthony, I'm going to let you jump in, especially if I misrepresent something, was changing the figure from, or the number from diagnosed, and making it really clear that we're talking about people living with HIV who know their status. Because in the 2016 plan, it was, it showed 100%. Anthony, do you want to kind of describe how HRSA, or how you come to the number of people living with HIV who know their status?
Sure. Can you hear me okay? So I wasn't 100% sure how the 2016 data had been presented so that both were displayed as 100%. But the way it's displayed here for 2018, we're just saying that 87% of the people living with HIV were aware of their status, which is pretty close to the goal of 90% that we're aiming for. So that's essentially saying that, approximately 13% are unaware of their status for whatever reason, whether it's lost to follow-up or something.
Yeah, and that's just based on kind of a standard HRSA algorithm. Is that correct?
Yes, this is coming from the HIV care continuum.
So even though this isn't really showing, anything that's happened since this group has been formed, we are able to look at the most recent data, and hopefully, not too far in the future, we'll have a place to actually keep these metrics public facing as a dashboard that we can continue to monitor. Is there anything else, Anthony, you wanted to talk about within this slide and the numbers?
I can give a little bit more explanation of each of the categories. So from there, linked to care is referring to percentage of people who have received a diagnosis of HIV within a calendar year and who have had one or more viral load CD4 tests within 30 days to 3 months of diagnosis. Retained in care is a little bit longer outlook. So it's someone who's received 2 or more viral load or CD4 tests at least 3 months apart during the calendar year. So we are seeing a slight reduction in the proportion there of people who are being retained in care. And viral suppression is the percentage of people living with HIV with a viral load test result below 200 copies per milliliter at their most recent viral load test during the measurement year. And this is of the people who know their HIV status.
Great, thank you, Anthony. And then this is also updated from 2016, which shows the disparities in those numbers.
Yes, and for the people living with HIV who know their status, we're still working on how best to present this, but essentially the breakdown by racial demographics is the percent of people who know their status that are each race or ethnic category. So 48% of the people who know their status are Black, 43% are white, 6% are Hispanic, and 3% were of other race.
Thank you, Anthony. So otherwise, just wanted to give a brief update on World AIDS Day planning. So at our last meeting, we discussed that the leadership team had created that communications plan emphasizing, finding as many opportunities to promote conversation in the community, to just start to break down barriers, break down some of the existing stigma, and obviously also tying that to a tangible ask or action. And this group, really thought, given the urgency of testing, HIV testing, and the dramatic decrease we had seen in testing in the community, because in response to the coronavirus, to really prioritize for this World AIDS Day, messaging around testing and also increasing opportunities for testing. So, our World AIDS Day planning team has been meeting very diligently and frequently for the last couple of months, and focusing on messaging and opportunities to promote the message of let's talk about it, know your status, with the tangible ask of get tested, talk to your family, talk to your friends about getting tested, why it's important to get tested, and here are the resources for getting out and getting tested in the community. The health department will be having an HIV drive-through testing event on World AIDS Day. We've also been working with Councilmember Hurt, who is going to act as the fiscal sponsor for a program we're pretty excited about for December 1st, but we're still trying to make sure all I's are dotted on that. So we'll be sending out more information on that. I've heard a lot of great activities happening in the community as well. Also just excited to be working with the mayor's office on some of this too. So we will be, I think, fulfilling the ask of this group to, really hone in on that message of testing for this World AIDS Day. And then those are all of the updates from me. Anybody wants to chime in? There's a lot of people on this call that are also part of those other pieces of work. And please feel free to jump in if I miss something or to add to.
Well, Julie, this is Sharon Hurt. I just want to thank you for believing in us and trusting us with this project. We're really excited about it. Our prevention team is also going to be going out with our mobile unit and working it and doing testing. And now that we've got a new location, it has provided us with some stability where we've got people actually calling, asking if they can come in and get tested. So we're excited that things are continuously picking up day by day. So thank you again. I appreciate it. And hi, everybody. And I especially want to say welcome to Sierra.
Thank you so much and congratulations.
Thank you. Thank you.
If there aren't any other updates from anyone else, and please feel free to share if you have World AIDS Day events coming up that that you want to let the group know about. But if there are no other updates, we can, I guess, move past the next item on the agenda. I think that we are just one person shy of having a quorum. Is that right, Julie? I believe we've got 8 on and we need 9.
Yes, I do have the bylaws. Let me look at them real quick. I can't ever remember if they're 50% or 50% plus 1 because we have 50%.
Okay. Well, maybe while Julie is looking at that, we can just take a moment. If you haven't had a chance to look at the meeting minutes from last time, you can take a moment to do that right now and just make sure that you're in agreement with everything.
Yeah, so the bylaws say a quorum for approving decisions made by the council should consist of a majority of the currently filled positions on the council. My interpretation of that, I guess, is a majority being 50% plus 1. So I believe we have 16. Let me look at the numbers on that, actually. Maybe we can move on to the next.
All right. Well, then I'll let Dr. Bullock.
Okay, thank you guys. Next item is our discussion of nominations and kind of the next steps. We did have one verbal resignation from Dr. Rufanti. Between September and November, we've actually had 4 different nominations from 4 different candidates to fill some of our gaps. This is kind of the first time we're actually putting some different people in. So currently our nominations are on a rolling basis. And I think we can probably leave that on a rolling basis right now and just continue to reassess that and then determine kind of at a future date as we continue to build up our our council whether or not we need to go to actually creating a governance committee that reviews the nominations, the bylaws, and et cetera. So I'm going to go through the nominations very quickly. There are 4 of them. They all are in your emails, so you have the opportunity to review their applications. And then we'll talk about the voting process after I go through these. So the first candidate we have is Dr. Ima Ahankai. I hope I've gotten that right. She's at Vanderbilt University Medical Center. She's an assistant professor in the Division of Infectious Disease and Vanderbilt Institute for Global Health. So her application is in your email. That's Dr. Ima Ahankai. The second candidate we have is Mr. Richard McKinnon, currently with Music City Prep Clinic. That would be the second person. Our third one is Mr. Devin Gwynn, currently with StreetWorks, serves as the Early Intervention Service Coordinator with StreetWorks. And the fourth and final person that we have is Meredith Brantley with the Tennessee Department of Health, is currently Director of HIV Programs for the Tennessee Department of Health. So those are the 4 candidates we have for nominations to the council. We have set up a survey monkey of sorts that Julie will send out after the meeting to vote on these candidates. We don't currently have a forum for discussing. We don't know if that's anybody's option or wants to do that. This is a publicly recorded meeting. So if there is anybody that has any concerns or suggestions, we can put those out there now. And then if there needs to be a offline conversation, I think we can facilitate that. Otherwise, the Survey Monkey will be sent out on these candidates. When you're reviewing these, also keep in mind to review the nominations bylaws, looking at making sure that these candidates do kind of fit the demographics in which we were looking to fill the council with. And if everybody would be okay with those and we get the nominations or the votes back, all 4 would be advanced to the mayor for formal appointments. So does anybody have any questions, concerns, suggestions about this current process or any of the candidates? I don't know if you guys have had the opportunity to see those.
I'll jump in quickly here just to say I apologize. We have quorum at 8. We do have quorum.
Okay. If there are no questions, we will send that Survey Monkey out to you. It will be coming from Julie. You can vote as appropriate. And then any additional comments or suggestions you can email to either myself, Claire, or Julie. And I'll send it back over to Claire if you want to go through the approval of the minutes.
All right. So hopefully you have had a chance to take a look at the minutes now. Julie sent those out earlier this week. Do we have any questions or revisions? All right. How about a motion to approve?
Motion?
All right. Do we have a second?
Second.
All right. And then if the rest of you all can just raise your hand, council members, if you vote to approve. All right. I see Brady. Just Brady. Anybody else raising your hand that I can't see?
I don't know how to do that, but yes.
Oh, okay, Dr. Hildreth approves. And Councilwoman Hurt. And all right, I think that's all we need.
Yeah, you and Dr. Bullock also approve, right?
Yes, we do. Very much approve. All right. So with that, we will move on to our next agenda item, which is a discussion of the Fast Track Cities Initiative. So just to give a little bit of background here, Dr. April Pettit, who is a member of the leadership team, brought the Fast Track Cities initiative to the attention of the leadership team a couple weeks ago. In short, it's a global partnership program that cities can sign on to and commit to goals for getting to zero. And there is a Fast Track web portal that allows cities to report on their progress, and the International Association of Providers of AIDS Care, which is one of the partners on this initiative, supports Fast Track Cities with a variety of different technical assistance and capacity building services. So the leadership team reviewed the criteria and felt that the program was well aligned with our EHE plan and work, and decided to go ahead and advance this as a recommendation for the advisory council to review. So we're excited to have a couple of guests here with us today that are going to tell us a little bit more about Fast Track Cities. So with that, I would like to welcome Dashiell Sears, Director of Advocacy and Public Policy, and Justin Hill, Regional Director of Fast Track Cities North America. So thanks for being here, you two.
Thank you for having us today. Hello, Nashville. My name is Dashiell Sears, and I am the Director of Advocacy and Public Policy here at IAPAC. And joining me is my colleague, Justin Hill. I'll let him introduce himself.
Hey guys, nice to meet you. I am a Tennessean too. I grew up in Memphis, and then I am now in Chicago where I went to school. So it's a pleasure to meet all of you. It's good to see my fellow Tennesseans. We look forward to talking to you today about Fast Track Cities and why you should join us. So thanks so much for your time.
So I'll start with a little bit about where Fast Track Cities really came from and what it means to join and how other cities have joined. So first, can everyone hear me okay? I just want to check. So Fast Track Cities started in 2014 with a partnership between IAPAC, the City of Paris, and UN AIDS and UN Habitat. Joining us is 300 different cities from around the world and counting, consisting of the Fast Track Cities network. The point of Fast Track Cities was to fast track both policies, practices, and knowledge surrounding HIV and AIDS, as well as TB and viral hepatitis. In doing so, we built a global web portal that consists of both resources, tools, trainings, and virtual workshops, as well as dashboards for all of the cities that are currently tracking their 90-90-90 data and their HIV data continuum. As we've grown with Fast Track Cities and the scope of our work, we've also been aligning ourselves with both regional and national plans for HIV. Notably, we in the UK, we started off Fast Track Cities working alongside their national HIV plan, and the UK actually adopted the national plan to just be Fast Track UK. So we're very excited to be working in North America, consistently between Canada, US, and Mexico. But in the US, we're also aligning ourselves with, firstly, ending the epidemic. We're in talks with the CDC and HHS to continue collaboration and alignment. And we are also looking into what will be the next phase afterwards. If ED will stay, if the Biden administration changes that. So we're always on our toes. But at a local level, the requirements of being a Fast Track City are twofold. The first step is the chief executive for the city, which in this case would be Mayor Cooper, would sign the Paris Declarations, which are 7 commitments, political commitments to advancing HIV policy, prevention policy, and elevating all kinds of transformations to be a positive impact for the community and keeping people first. The second fold would be for, in this case, Nashville, to share their 90-90-90 data on an annual basis, which would then be turned over into the Fast Track Cities annual report. In this case, we actually have funding to be able to build the Fast Track City data dashboard portal for Nashville currently. And afterwards, your interaction with Fast Track Cities and IPAC is really dependent on how Nashville wants to interact. So beyond the tier requirements, we conform to how Nashville wants to have that kind of touch with IPAC. We offer, again, trainings, workshops. We offer a technical implementation packet as well, and on-site consultations when we can actually do on-site stuff. And it's really tailored to however Nashville would want to interact. We pride ourselves in being a facilitator of knowledge exchanging and knowledge sharing. We're currently building our best practices for HIV implementation and HIV prevention trainings. We have our best practices for COVID and HIV. And we are also extending our focus towards engagement with our administrative officials, both at the state and federal level, to ensure a holistic approach to HIV prevention. There's no cost to actually being part of Fast Track Cities beyond just maintenance of a dashboard. But again, we look for that for Nashville as well. But we offer to you our resources, our consultation, our knowledge, and a platform to be able to exchange and share information internationally. Justin, do you have anything else to add? Did I miss anything? I just kind of threw everything there, but.
Sorry, I think you did a very thorough job. And if there's questions, I'm more than happy to answer anything. And if there are any other things that you guys want to talk about, we can talk about examples if you wanted or what have you.
Would it help anybody if I pulled up the Paris Declaration so we could see agreements and?
So I actually do have a slide deck with the Paris Declarations and how cities can operationalize themselves. If I'm able to share, I'm happy to share those.
Yeah, if you want, I can attempt to make you the presenter right now so you can share it.
Okay.
If you have that ready to go, let me see. Okay, it looks like it worked.
Okay.
I think my main question just on looking at that, and I, just to fill the quiet for a second, it looks like there is a syndemic approach in the updated Paris Declaration, and while the state is working on that ending the syndemic process, and we are locally working towards alignment with that, but also while moving forward with the implementation of our plan. And I know, for example, like Rajiv is working internally with our Hep C, our main Hep C person. And so there are those kind of alignments happening, but it's not necessarily explicit in our current plan. So I'm just curious about that.
So I can speak to a little bit, and I'll let Dash come in and talk about the Paris Declaration. So yes, you're right. We are trying to take a social determinants of health approach to how we talk about HIV and reducing down to zero, and how we make that approach. And so part of that is understanding that it takes like a concerted effort in a locality or municipality for people to achieve those kinds of things, especially at an epidemiological level. And so that's one of the reasons why we're doing it. what specifically, Julie, were you what was the heart of your question?
Well, so I'm trying to remember which kind of syndemic issues. So it was HIV. So we will focus efforts on all people who are vulnerable to HIV, TB, viral hepatitis, and other diseases. So currently, our ending the HIV epidemic plan for Nashville, for the city of Nashville, is focused on HIV. But obviously, we're finding opportunities to, within our own, spheres of work to align with the work of others working on viral hepatitis and other issues. Our state is working on a plan and ending the syndemic plan, but they're in early stages of the planning process, and that's for HIV, viral hepatitis, overdose, substance abuse, and other STIs. It's not TB, right, Claire? So, and then locally, too, I know at least with our trauma-informed care work group, we're specifically interested in the syndemic of trauma and HIV. So,
exactly.
Yeah, so I guess I'm just curious, does this change in the Paris Declaration require us to be aligning our efforts in the same way as laid out here, or is there, room for that local kind of priorities and local approaches?
Exactly. A great question. That's perfect. So, and Dash, please feel free to jump in. But so part of this is that we want to create tailor-made, locality-specific approaches to helping, right? And so what's really great about Fast Track Cities is like you're saying, you're working on your ending epidemic plan, which is focused around like health departments, the community stakeholders. With Fast Track Cities, we also try to activate the executive function in the locality and the municipality to further along to like when there are, so when you take this endemic approach in the social determinants of health, you talk about how like policies have to also support the efforts being done. And so we are able to facilitate that conversation if that's something you want to have. And we want to make sure that it's part of that development process of just thinking through how you want to do it. And so one of the things that we have in addition to that Dash highlighted was that peer-to-peer conversation. So you could talk to another locality like Jackson, Mississippi and say, so how are you tackling this? We might not be able to do it the way they're talking about sex workers in Montreal and having all this full-on conversations that don't fit what we're trying to address here, but we can look at some of our neighbors and take some of those best practices. So that's another added advantage. And so to answer your question, we lay out all of our different services, and what we're trying to do is facilitate the kinds of conversations that localities, municipalities, and cities and or states are interested in having, and then providing the resources to back into how do you do that from a policy perspective. Has that been accomplished in another health department that's similarly situated, that has a southern populations with a similar political arena in which things are happening? And so we try to make sure that we can calibrate our support, our technical assistance, our technical capacity building to match what you need. So that is boilerplate information. Dash, do you want to throw anything else into the fire?
No, you hit the nail on the head. We try to tailor ourselves to whatever locality, whatever their needs are. So we do have several places that are focusing on, say, uptake, or they're focusing on adherence. But we hold true that most cities, or all cities, know more about their local HIV epidemic than like us or other cities. But it doesn't mean that the issues those cities are working on are in a vacuum. Maybe the focus in one place is not directly on, let's say, trauma-informed care, but it doesn't mean that it's not there. So not only could you learn from other places that are already working on the same issues, you could also, just by virtue of being part of the initiative, could become a leader in certain aspects that maybe are not necessarily being addressed directly. So it's a vice versa communication that we can help facilitate. And we can also draw up workshops, trainings, and even formulate conferences if needed to around those specific issues if there's enough buy-in as well. So we do look for those opportunities, especially in an environment where it can be virtual. We can share that information. So I did want to bring up the Paris declarations that are here on this. I hope you guys can see that it's 7 different declarations. So these are very overarching, just like an umbrella. They do encompass both commitment to end AIDS and public health threat by 2030, keeping people at the center of everything that you do, addressing causes of risk, using AIDS response for social transformations, accelerating appropriate responses to local needs, mobilizing resources, and uniting its leaders. So these are more so political commitments that executives who sign the declarations would make. But everything beyond that is geared towards engaging these 7 commitments. What you've just described and talked about falls under everything that would be under the Paris declarations already. So it's not like we wouldn't be asking for you to change anything that you're currently doing, as everything you're currently doing is already aligning yourselves. As far as aligning with the state government, that would be up to how Nashville would like to interact with the state of Tennessee.
So are there other questions from council members? I think I have a quick question, if that's okay. I was looking at your website earlier today and read something about eliminating HIV stigma in healthcare as something that you all do. And I wondered if you could share a little bit more about your work in that area. And I think most people on this call would probably agree that this is one of the most sort of pernicious and difficult things to root out, especially here in the Southeast.
Exactly. So we actually worked with, was it the U=U campaign? Was it prevention? I'm blanking on the name now. It was U=U.
Prevention Access campaign.
Prevention Access, yes. Bruce Richmond and yes. We actually developed a online training tool for clinicians to take. It does have continuing educational credits with it. We would recommend that clinicians that are part of the Fast Track Cities take those continuing education credits to learn about clinical care and the language behind U=U, the practice behind U=U. So we actually developed that, and those are available online. We also include U=U in our conversations, our workshops, and our best practices when it comes to technical implementation in both clinical care and in the community.
Awesome, thank you. And I want to give everybody else just a moment to ask any other questions.
You had spoken about like some of the other cities that are similar to Nashville. I was wondering if you could give kind of like, especially towards the Southeast or like the medium-sized cities that you deal with that are similar to Nashville. Can you identify them, kind of like what kind of work that they might be doing, which is similar to us?
We've recently done workshops with Charleston and Columbia, South Carolina. We also recently did the same workshops, implementation workshops with Dallas and with Houston, although Houston is very large. We also are working with Miami-Dade County. And we are also working with Durham in North Carolina. They have signed on and will be doing a setup workshop with them on World AIDS Day as well. As far as outside of the Southeast, well, actually, I shouldn't forget to mention, we also have Jefferson County, so Montgomery, Alabama, is also a fast track city. They have provided a lot of detail with their CFAR program out of University of Alabama. And so as far as those are who we currently have, we also have New Orleans and Baton Rouge in Louisiana. So those cities have been very forward in sharing practices, learning from other cities, being involved as fast track cities, and for any workshops and trainings, we have included them. And finally, I think Justin, I think you're probably going to say Atlanta metro area.
Yeah, I was trying to think about, like, are we talking about similar in size? If I remember my Tennessee geography, is Nashville, how many people are in the geographic area of Nashville right now?
If you consider our transitional grants area for Ryan White, that's the 13 counties in Middle Tennessee, we're looking at approximately 1.8 million people.
1.1 million people?
1.8.
So, 1.8. So,
yeah, and Nashville Davidson itself is maybe about 800,000 or so.
Yeah, okay. So in the 800,000 range, right, we would be saying, like, so Washington, D.C., there are 28 cities in the United States that have signed on the Fast Track City. And we've definitely been focused on the South, and we have a large presence. I would say, like, comparable, like where there's two big universities, both Fisk and Vanderbilt, kind of like being the bookends of the area. You could look at Washington, D.C., you can look at Atlanta, if you want to do the metro-wide area. And so we have established relationships with both the public health departments and the executive functions within those counties and or cities or municipalities. And so there would be a large reservoir of collegial cities to talk to about how to approach this. And one of the things I wanted to emphasize is that you guys are already on your way with the EHE, and which is totally cool because Fast Track City doesn't add any work to your plate. All we're trying to do is be that auxiliary to help you utilize our compendium of tools to really build out your EHE planning and to think about it strategically and to provide you with access to other cities to really, like, I hate to use this example, but to be kind of like the never ending story and dream big. Any dream you have, we can probably help you find the person that are doing it. We want to make sure that there's opportunities and that we can really fill in some, I don't know, I wouldn't say gaps because I've been reading up on Nashville. You guys are doing really good work. But just opportunities for us to all strategically row in the same direction.
Thank you. Actually, it was nice to hear that some of my brethren, Ryan White cities in the Southeast are also involved, so fantastic. Thank you.
Awesome.
Any other questions?
So I think, our understanding is that there's no cost to the city. The requirements are the data sharing and signing the Paris Declaration. Looking at the dashboards of other cities, it looks like their data collection methods are not changed. It's not going to be, there's requirements that are just not feasible because of how our system operates.
To be honest, we do have a strategic information team that really handles a lot more of data, but in general, any data that you would share with the CDC or with the state that involves the 1990, you could basically CC us on it, and it would be the same data we would ask anyways. So if you're already collecting and demonstrating that data, it wouldn't change. Our requirements for it wouldn't change at all. If there were any requirement changes, depending on how your data is collected, there can always be adjustments made or or that competition can happen later. But from what I've actually seen, from what you guys collect, it doesn't look like it would be an issue at all.
Okay. So there aren't any other questions for our guests. But I believe that we are going to be meeting with the mayor at some point in January, I want to say, Julie, something like that. Of course, we would need Mayor Cooper's buy-in. And this is something that we would need to bring to him at that time. So I just open it up quickly for discussion. Do people feel like this is something we want to advance to the mayor? And are there any concerns that anybody has?
If you don't mind, I just thought of this, please excuse me. You said about the funding for the dashboards. Do you put out RFPs? How would you apply for those funds for creating dashboards?
So dashboards can happen one of two ways. One, it can be self-funded, or two, we'll have funding to be able to build a dashboard. Now, we actually do have funding to allocate to build a dashboard for Nashville. You wouldn't necessarily have to worry about raising this funds. The other option is if you, if say a place had to do a self-funding, we would help with resource mobilization. So we would help locate grants and provide assistance to locate where you can develop those funds from. It's one of the assets that we bring. We do have a lot of collaborations with other places that can help with putting together grants or funding. However, we can assist. Us as IPAC and as Fast Track City, we don't necessarily give out funding unless we have the grants developed to be able to do so. So we do offer that kind of resource mobilization assistance as needed. But for the dashboard for Nashville, we do have separate funding for that.
So I don't think we have, we plan to have a formal vote on this, but if anybody has anything to add to this discussion now, please do. Otherwise, I will take silence as assent.
I'll just say real quick, I think not utilizing these free resources would be a huge mistake. It's there and available for us. I know you said we're not going to vote, but I really think we should try to advance this on to the mayor and get the mayor's office behind it as well.
Thank you, Brady.
I agree with Brady completely.
All right.
I also agree with Brady. And for disclosure, I was planning on going to the last Fast Track Cities conference before COVID hit. So I think it's a great program, and yeah, definitely to follow up.
All right. Well, thank you so much to Dashiell and Justin for being here today and sharing with us. So it sounds like we have some agreement amongst the council that we'd like to move forward with this. So we will plan on doing that when we next meet with the mayor. So I will pass it back to Dr. Bullock now.
Thank you so much for having us.
Thank you, guys.
Thank you. All right, thank you, Claire. Are there any additional announcements that anybody from the council has as we prepare to adjourn today? Want to thank Dash and Justin for joining us today. I think this is a great opportunity for us, and looking forward to working with you all. Sierra, welcome to your first meeting with us, and look forward to working with you. Our next meeting is not until January 21st, 2021. So happy holidays, Thanksgiving, Christmas. Stay safe, stay well with all your families, and hoping 2021 brings us much more health and wellness and advancements than we've had this year. We've worked together, we've cooperated well, but we're hoping for a great 2021. So wishing all of you the best through this holiday season, and feel free to reach out to any of us should you guys need anything. Also, don't forget to vote for our 4 nominations as well. I think we've had a great meeting this time, and looking forward to a great new year.
Thanks, everybody.
Thank you, guys.
Bye, everyone.
Bye-bye.
Thanks, everyone.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information about this and other programs, visit nashville.gov.